Good morning, everyone. Am I audible?
Yes,
Yes.
doctor.
Okay. Good morning, everyone. Myself, Dr. Anu Garg, postdoctoral fellow Neonatology in GEIMS, Dehradun. I'm going to start PPHN's physiology and classification. Learning objectives. First is transitional physiology of PPHN, its classification, and pathophysiology of PPHN. Introduction. What is PPHN? PPHN is persistent pulmonary hypertension of newborn, which occurs when there is increased pulmonary vascular resistance even after birth, resulting in right to left shunting of the blood through fetal circulatory pathways. This in turn leads to severe hypoxemia that may not respond to conventional respiratory support. Epidemiology. There is overall incidence of 1.8 per 1,000 live births. Incidence in late preterm is 5.4 per 1,000 live births, and in term, it is 1.6 per 1,000 live births. Mortality ranges from 7.6 to 10.7%, which is significant. Now, there is the fetal circulation versus post-umbilical cut circulation. So here placenta receives oxygenated blood and through umbilical vein, it goes through ductus venosus and from there it reaches the IVC. From IVC, blood flows through foramen ovale here from IVC, from right atrium, the blood flows through foramen ovale and to left atrium. Here you can see, and to left atrium, then to left ventricle, and the blood goes through ascending aorta to and body receives oxygenated blood. From superior vena cava, uh, uh, blood comes in right atrium, and from right atrium, oxygenated blood bypasses through pulmonary artery and goes through ductus arteriosus, and it goes to aorta. And blood from aorta goes through descending aorta, and lower body receives the blood. Now, from descending aorta and ascending aorta, blood goes through umbilical artery and placenta receives the deoxygenated blood. Now, what happens in neonatal circulation? As soon as the placenta circulation is eliminated, baby takes its first few breaths at birth. There is 5 to 10 times decrease in pulmonary vascular resistance, and there is reversal of ductus arteriosus shunt. And because of increased LA filling pressures, the foramen ovale is closed. And as soon as placenta gets cut, there is decreased prostaglandins and there is increased PaO2 pressures, which causes ductus arteriosus closure. So from here, blood goes from ductus, as ductus arteriosus is closed and there is increased pulmonary blood flow, oxygenated blood comes from the lungs to left atrium, then to left ventricle and to aorta, and body receives oxygenated blood. Now, what happens in PPHN? Because of increased perinatal intrauterine causes and neonatal causes like meconium aspiration syndrome, respiratory distress syndrome, congenital diaphragmatic hernia, sepsis, congenital pneumonia, congenital heart conditions, and like parental causes like oligohydramnios, pulmonary hypoplasia, SGA, or LG there's increased pulmonary vascular resistance and pulmonary vasoconstriction, which leads to decreased pulmonary blood flow, causing hypoxia, acidosis, and increased right to left shunting. And this vicious cycle goes on and on. Now, what happens in utero? In utero, there is increased pulmonary vascular resistance because of mechanical compression of pulmonary blood vessels due to increased fluid in alveoli. There is abnormal smooth muscle activity. There is increased production of vasoconstrictors like endothelin 1, thromboxane, and leukotrienes. And there is also low levels of vasodilators like nitric oxide and PGI2. And there is hypoxic pulmonary vasoconstriction. This happens in utero. What happens after birth in pulmonary circulation is there is increased pulmonary blood flow, there is reduction in pulmonary vascular resistance, and clearance of lung fluid. Now, the central role in pulmonary vascular transition is played by pulmonary endothelial cells, nitric oxide, and arachidonic acid metabolites. Now, what happens is fetus prepares for extrauterine transition late in gestation by increasing pulmonary expression of nitric oxide synthase. At birth, pulmonary endothelial nitric oxide production is increased because of increased oxygen tension and shear stress. This exerts its action through soluble guanylate cyclase, and it increases the CGMP levels. CGMP is a central mediator of vascular relaxation, and PDE5 catalyzes CGMP. So, if we inhibit PDE5, that is through sildenafil, we can use it for the treatment of PPHN. Now, the arachidonic acid prostaglandin pathway. Here, cyclic oxygenase 1 enzyme acts as arachidonic acid to produce prostaglandin I2. It activates adenyl cyclase to increase CAMP in vascular smooth muscle cells, which leads to vasodilatation. So here also PDE3 catalyzes CAMP. So if we inhibit this by milrinone, it can help in PPHN treatment. Now the classifications of PPHN. First is physiological classification. That is primary and secondary. Primary is there is increased pulmonary vascular resistance without any structural heart or lung disease. In secondary, there is increased PVR, but there is structural abnormalities like severe parenchymal lung diseases. Next classification is etiological classification. There can be maladaptation. There is abnormal pulmonary vascular response in lung parenchymal disorders, or there is underdeveloped vasculature. There is decreased pulmonary vasculature as seen in SG or oligohydramnios baby. Or there can be remodeling vasculature likely due to excessive pulmonary vascular smooth muscle thickness. Severity-based classification. Mild is if baby responds to minimal oxygenation or ventilation. Moderate is if baby requires mechanical ventilation plus minus inhaled nitric oxide. And severe, there is refractory hypoxemia, may need ECMO. Radiological classification. First is black lung PPHN. There is clear hyperlucent lung fields and it is seen in idiopathic PPHN. There can be white lung PPHN. There are diffuse opacities in lung seen in meconium aspiration syndrome or respiratory distress syndrome. And there is small lung PPHN because of reduced lung volume as seen as congenital diaphragmatic hernia or pulmonary hypoplasia. Next is echo-based classification. It is based on pulmonary artery pressures. Mild PPHN, there is decreased pulmonary artery pressure as compared to systemic pressures. Moderate PPHN, both pulmonary artery pressure is all equal to systemic pressure. And in severe PPHN, pulmonary artery pressure is more than systemic pressure. Echo-based classification next is based on ventricular function. First is normal LV or RV function. It is likely due to primary vascular cause. Next is depressed LV function secondary to myocardial dysfunction. Example in hypoxic ischemic encephalopathy. Next is RV hypertrophy and septal flattening. It indicates severe pulmonary hypertension. Now, what is idiopathic PPHN? Idiopathic or black lung PPHN is most common in term and near-term newborns. There is significant remodeling of the pulmonary vasculature occurs along with vessel wall thickening and smooth muscle hyperplasia. There is abnormal muscularization of intra-acinar arteries, which leads to increased medial thickness of large muscular arteries, resulting in decreased cross-sectional area of the pulmonary vascular bed, and it increases elevated pulmonary vascular resistance. Its pathophysiology, there is constriction of the fetal ductus arteriosus in utero only from exposure to NSAIDs during third trimester. There is humoral growth factors released by hypoxia-damaged endothelial cells, which promote vasoconstriction, and there is overgrowth of pulmonary vascular media. Reactive oxygen species such as superoxide and hydrogen peroxide may play a role in the vasoconstriction and vascular remodeling associated with PPHN. Affected infants do not vasodilate their pulmonary vasculature appropriately and in response to birth-related stimuli, and they present with profound hypoxemia and clear hyperlucent lung fields on radiography. Thus, the term black lung PPHN is given to this. So pathogenesis in whole is prenatal factors like maternal NSAID or SSRI use, premature closure of ductus arteriosus, cesarean delivery, post-term 40 more than 41 weeks, LG baby, abnormal placenta, altered lung development, or any cardiovascular abnormalities, and postnatal factors like hyperoxia, oxidative stress, ventilator-induced lung injury, asphyxia, or any inflammation or infection. This all leads to injury to the developing lung circulation, which leads to there is impaired vasoreactivity, increased angiogenesis, and altered vascular structure, which leads to PPHN, leading to failure to decrease the pulmonary vascular resistance at birth, extrapulmonary shunting across ductus arteriosus, or patent foramen ovale, and severe hypoxemia. So take-home messages: PPHN causes right to left shunting and severe hypoxemia. Etiology includes parenchymal lung diseases, pulmonary hyperplasia, and vascular remodeling. And management targets include reducing PVR and improving oxygenation. Thank you.
So its presentation is by Dr. Shivendra from SCPJ. Shivendra?
My topic is PPHN secondary to lung disease, cardiorespiratory management. Good morning, everyone. I'm Dr. Shivendra Kumar. I'm presenting this topic. So my learning objective will be diagnosis, supportive management, ventilation and recruitment, and pharmacotherapy. So is my screen visible to everyone?
Yes.
Yes, sure.
2D echo is the gold standard for diagnosis. It should be performed in all the infant with suspected PPHN to exclude the congenital heart disease, to document hemodynamic shunting, measure the pulmonary artery pressure gradient, and additional finding like tricuspid regurgitation or ventricular septum that is flattened or bowed to the left suggest pulmonary hypertension. The common parameter which we see in 2D echo for diagnosis is presence of ductal and or foramen ovale shunt with right to left direction of flow. The second is flattening or deviation of the interventricular septum. Third is right atrial enlargement. Fourth is tricuspid insufficiency and systemic or near systemic right ventricle pressure estimation from Doppler study that is suggestive of TR in conjunction with systemic blood pressure measurement. And the fifth and last one is right ventricular dysfunction. That also suggests severe pulmonary hypertension. Another parameter is tricuspid annular plane systolic exclusion, that is TAPSE. This is obtained in 4-chamber view using M mode. This refers to the distance traveled by tricuspid annulus from diastole to systole, and it is measured in millimeter. This has prognosticatic value also. TAPSE of 4 mm is associated with increased need for ECMO or death in PPHN. So this is the image. This is how it is measured, indicating RV dysfunction. This is the TR. This is the TRZ and RVSP in 2D echo. This is a slide in which you can see interventricular septum bowing into the left ventricular cavity. another slide showing TRVZ. And this is the position of the left ventricle and shape in 2D echo. The normal positioning of the ventricular septum with O-shaped LV. This is the shape of the LV and concentric RV. In second scenario, this is midline septum with D-shaped LV. This also suggests PPHN, and this is the severity of the PPHN, where septum is bulging to the left ventricle and the LV is concentric in the shape. Now comes the management of the PPHN. The first part is supportive measure. In this, we maintain the temperature. The optimal temperature is 36.5 to 37.5. And then nutrition, maintain euglycemia, calorie intake, and maintain calcium level. Avoidance of stress and handling in the child, like eye patch, ear plug, urinary catheterization, morphine, fentanyl infusion, and no paralysis should be given. Then in supportive measure, we should maintain pH more than 7.25. Preferable range is 7.3 to 7.4, and no alkali infusion and no hyperventilation is preferred. Alkalosis causes cerebral vasoconstriction that worsen the neurodevelopment outcome. Then oxygenation, the target SpO2 preductal is 90 to 97% and postductal is 70 to 80% is acceptable if the lactate is less than 3 and urine output is more than 1 ml per kg per hour. The target PO2 range between 55 to 80, and hyperoxia causes a reduced response to NO and increases the free radical injury. That's why hyperoxia is avoided. This is the graph showing oxygen saturation and PVR that should be kept between 90 to 93, 90 to 93%. This is the image depicting PO2 around 60. That has better outcome. And this is a chest X-ray pattern and management of PPHN. There are basically 3 types. One is secondary PPHN due to parenchymal lung disease, due to loss of lung alveolar space like HMD. Second is idiopathic pulmonary hypertension, that is black lung PPHN. And third is secondary PPHN due to lung hypoplasia like CDH. So in the first case, we give early surfactant therapy for lung recruitment, and other causes are also there like meconium aspiration syndrome. Then mass pneumonia is also one of the major cause which causes this thing. So in this case, the main target will be lung recruitment, which increases the mean arterial pressure. Again, the target will be SpO2 of around 90 to 97%. PaO2 of 55 to 80, pH is 7.3 to 7.4, and PCO2 between 45 to 60. And the next step will be vasodilator therapy that will be discussed subsequently. In case of CDH, we should avoid overexpansion and we should keep the SpO2 target near lower range, 85 to 95, where in case of pulmonary disease, it was 90 to 97%. PaO2 we can keep between 45 to 60 mm of Hg, pH between 7.2 to 7.3, and CO2 between 30 to 60. In case of idiopathic normal lung compliance, we can keep this, avoid excessive PEEP and mean pressure that may worsen PPHN. This is the PPHN type based on echo diagnosis. The first one is no or mild PPHN with no cardiac dysfunction. The second one is PH with no cardiac dysfunction or RV dysfunction. This is pulmonary arterial phenotype. And third is PH with LV dysfunction or biventricular dysfunction. This is also called as pulmonary venous phenotype. Here you can see the LV dysfunction. In this case, second phenotype, we can see the RV dysfunction, and the first one was no cardiac dysfunction. Ventilation and lung recruitment strategy. Lung recruitment is an important step while managing neonates with PPHN. Lung recruitment is a common cause of failure of vasodilator therapy. We should optimize the recruitment of the lung with the use of PEEP to achieve adequate lung expansion between 8 to 9 ribs to maintain FRC. Overinflation, that is more than 9 ribs, can impede the venous return and causes systemic hypotension, and this worsen the right to left extra-alveolar shunt. Inflation, that is, if we are keeping less than 7 ribs, that will cause atelectasis and increases right to left intrapulmonary shunt. What is the role of surfactant in pulmonary hypertension in PPHN? The indication is intubated patient with parenchymal lung disease with oxygenation index between 5 to 7 or requiring 40% FiO2 to maintain SpO2 of 90%. Surfactant and INO slowed the progression of HRF and reduced ECMO death. Homogeneous lung recruitment enhances the ability of oxygen and enhanced vasodilators such as INO to reach pulmonary vasculature. A trial of exogenous surfactant is beneficial to recruit the lung in secondary PPHN because of mass, RDS, or pneumonia. There is a role of intratracheal surfactant also recommended in PPH with pulmonary diffusion impairment in all causes except CDH. Precaution is we should avoid hypocapnia and avoid hyperinflation, and CDH and idiopathic PPHN is contraindication of surfactant therapy. This is the pathway of vasoactive agent in pulmonary circulation. Sildenafil act by inhibiting 5-deacetyl phosphodiesterase inhibitor. Then milrinone act by phosphodiesterase 3 inhibition. Then this is the mechanism of action of alloprostidyl. This is PGE1. And bosentan inhibit endothelin A and endothelin B. That will be discussed later. What is the role of INO? INO is the cornerstone of PPHN, first approved by FDA in 1999. And this reduces the PPHN related mortality from 33 to 10% in developed country. And this also reduces the need of ECMO. Meta-analysis of 7 RCT showed that 58% of term and near term responded to INO in 30 to 60 minutes of treatment. Now, what is the doses and indication? Indication is mechanical ventilated term and near term infant with HRF with clinical or radiographic evidence of PPHN. Second indication is oxygenation index more than 25. Dose is 20 ppm. We should start from 20 ppm and then wean off. Monitoring, while the therapy we can monitor by chest X-ray, FiO2, pulse oximetry. Then what is the contraindication? Then CDH, left ventricular dysfunction, presence of ductal dependent systemic circulation, like HLHS is contraindication of the INO therapy. And class of recommendation is the first, and level of evidence is A, that is data derived from multiple RCT. This is a slide which depicts summary of the INO. This is the role of inhalation of INO, that is 20-20-20 rule. It is like when to start, at what dose we have to start, and how to increase. So this is started at the dose of 20, at the oxygenation index of 20, and response is measured by PF ratio that should increase by more than 20. Then the weaning rule is 60-60-60. That is when we have to stop that after 60 minutes of the treatment, FiO2 should be less than 60% and increase of the PaO2 should be more than 60. If this scenario is fulfilled, then we can start weaning the INO. And there is based on this, we classify it complete response or partial response. Then what is the contraindication of INO? There are 3 major contraindications. The first one is presence of major congenital anomalies. Second is grade 3 or 4 IBH. And the third is presence of duct-dependent cardiac circulation like HLHS or interrupted aortic arch or critical AS. Then most common side effect of INO is methemoglobinemia. That's why methemoglobin level should be monitored during treatment. This is monitored at 2 hours, 8 hours after starting the therapy, and then once a daily if the patient is on INO therapy. Some centers stop checking methemoglobin level after the first couple of days if the level is below less than 2% or INO dose is less than 20 ppm. This is the picture which is depicting role of INO with or without surfactant. So in the first case, asymmetric lung disease, where surfactant deficiency is there, you can see the complete alveolus is collapsed and another one was distended. In the second case, INO was given without lung recruitment or surfactant. So in this case, the alveolus was still collapsed and the another one was over distended with uh, nitric oxide therapy. In the third scenario, we have given surfactant plus lung recruitment plus INO. In this case, you can see the both sides the alveolus is dilated and the oxygenation is better in this case. There was one trial which shows the efficacy of inhaled nitric oxide in preterm less than 34 weeks. This was the systemic review and meta-analysis that was published in January 2024. The objective of the study was effectiveness and safety of the INO treatment in preterm less than 34 weeks. Selection criteria was preterm infant with less than 34 weeks of age. So this study shows that the use of INO was better and the outcome was better in preterm. And this study suggested that INO has promising role in the use of BPD, and this also decreases mortality in patient. So this is the scenario RV dysfunction with PPHN. In this case, we can use INO or milrinone, and the second line will be PGE1 and third line is vasopressin or norepinephrine. Basically, we have to give positive inotropic effect that reduces the RV afterload and maintain adequate preload. That's why in this case, INO is preferred. Now comes the second drug, which is milrinone. Milrinone is phosphodiesterase 3 inhibitor that increases cyclic AMP level in myocardium and vascular smooth muscle, that thus act as inodilator. Indication is PPHN associated with ventricular dysfunction. This is adjunct to INO therapy if there is inadequate oxygenation response to INO. Loading dose is 50 to 75 microgram per kg IV over 1 to 3 hours, and maintenance dose is 0.3 to 1 microgram per kg per minute for 35 hours. Contraindication is severe renal dysfunction, shock, or severe hypotension. So, milrinone is effective in INO-resistant PPHN. This is the same mechanism of action which increases cyclic AMP level. Milrinone decreases PVR in PPHN. This was the study conducted by Rashid and this is a scenario in which LV dysfunction with PPHN was there. In this scenario, INO is contraindicated because INO is selective pulmonary vasodilator. So if we increase the pulmonary vasodilator, if we give INO, this will causes more blood flow to pulmonary artery. This will in turn lead to increase in pulmonary blood flow to the left atrium and finally to left ventricle. And the left ventricle is already dysfunction. So this will cause over pressure to the left ventricle, which is already damaged. That's why inhaled INO is contraindicated in LV dysfunction. Now the third drug is sildenafil. This acts as by phosphodiesterase 5 inhibition, which increases the cyclic GMP level and causes vasodilatation. Indication is treatment of PPHN or BPD associated pulmonary hypertension, especially if INO is not available. Second is suboptimal response to INO, especially if associated with normal blood pressure and good ventricular function. Third is difficulty in weaning INO. The dose is IV dose is 1.4 mg per kg per hour for 3 hours, followed by 0.07 mg per kg per hour for maintenance. And per oral or OZ doses start at 0.5 to 1 mg per kg per dose and increase to 2 mg per kg per dose, 3 to 4 times a day. Maximum dose is 8 mg per kg per day. We should monitor systemic blood pressure, perfusion, lactate during the treatment, and contraindication is severe liver dysfunction, shock, or severe hypotension. This is the Cochrane review, which was done on sildenafil for pulmonary hypertension. The type of intervention was sildenafil versus placebo, sildenafil versus other pulmonary vasodilator, sildenafil, and other pulmonary dilator. So the primary outcome was monitoring of pulmonary arterial pressure in mmHg, then oxygenation or FiO2 requirement, cardiac output, and mean blood pressure. Secondary outcome were changes in pulmonary vasculature. So this was the outcome. This trial shows that sildenafil used for treatment of pulmonary hypertension has potential for reducing mortality and improving oxygenation in neonates, especially in resource limited setting where INO is not available. The another drug is prostaglandin E1. The indication is PPN with right ventricular failure because of afterload to maintain ductal patency, reduce RV afterload, and promote pulmonary vasodilatation. Dose is IV doses 0.01 to 0.05 microgram per kg per minute. The next drug is endothelin receptor antagonist, that is bosentan. The indication of bosentan is PPHN not responding to oxygen, INO, and sildenafil. Chronic management of pulmonary hypertension, in this case also especially associated with CDH or BSG, we can use bosentan as a drug. Dose is 2 mg per kg per dose, per oral dose twice a day. We have to monitor liver function during the treatment, and precaution and contraindication is it is hepatotoxic. That's why it is avoided in elevated level liver enzyme case. Then the role of hydrocortisone, in addition, glucocorticoids might have effect on the lung in PPHN. The dose is 4 mg per kg followed by 1 mg per kg 6 hourly in PPHN. That is resistant to conventional therapy, showed improvement in oxygenation and PP with reduced in need for vasopressor. High dose hydrocortisone also inhibits phosphodiesterase 3 and phosphodiesterase 5 and enhances oxygenation response in PPHN. The role of MgSO4, there was a trial conducted in Egypt by in 2020 that shows the nebulized magnesium sulfate may be effective therapy in neonate with severe PPHN. Magnesium sulfate acts by calcium antagonism. It blocks calcium entry into the smooth muscle cell, thus promoting vasodilatation. Magnesium sulfate is safe and cheaper alternative in first-line management in moderate PPHN when all other conventional treatment fails and are contraindicated or not available. Loading dose is 200 mg per kg, which is given over a period of 20 minutes followed by continuous infusion, that is 20 to 150 mg per kg per hour. And we should maintain the target level of serum magnesium between 3.5 to 5.5 millimole. Magnesium sulfate could be used as a first-line vasodilator in developing country because of its low cost and high efficacy. Parenteral magnesium sulfate is easy to administer and monitor during treatment. When magnesium sulfate is used, systemic hypotension can be adequately controlled with inotropes. So this is the this is the trial meta-analysis which compared the effectiveness of the different vasodilators. They compared mortality reduction. The mortality reduction in case of milrinone use, the odds ratio was 0.125. With sildenafil, odd ratio was 0.14. If we used milrinone plus sildenafil, then odds ratio was 0.05. All studies showed significant and better survival than placebo. And in case of magnesium, magnesium is less effective than sildenafil. This study was published in 2024, and this was the meta-analysis which included 16 RCT. And this is the vicious cycle of PPHN, in which if there is a pulmonary vasoconstriction, in this case pulmonary vascular resistance increases, which in turn reduces the vascular pulmonary venous return, which decreases the LV preload, and this causes systemic hypoxemia, further decreases coronary perfusion. This leads to RV dilatation, and this decreases the RV contractility, and then again this vicious cycle is followed, which lead to the severity of the illness. The another type is hyperkinetic.
I think Shivin,
Yeah.
Dr. Shivin, you should really take care of time. We have exceeded your time. You should wrap it up now.
Okay. Hyperkinetic PS, this is associated with CSD with left to right shunt, ASD, VSD, and PTA. The management strategy is fluid restriction, diuretic therapy, pulmonary vasodilator, and sepsis, or optimize the antibiotics. This is the summary of the treatment, in which first one is minimal stimulation, eye cover and ear mops, then supplemental oxygen ventilatory support. Then this is the intratracheal surfactant therapy, which was given for lung recruitment, then oral sildenafil. Then this is the ventilation setting. We should maintain tidal volume more than 6 ml, which we have discussed already. And then drugs intervention, then endothelin receptor antagonist, and this is the role of iron. PPHN and Indian perspective, most common management strategy being followed in Indian setting is pulmonary vasodilators, then inotropes. Most common used was milrinone. Then in only 25% cases, a respondent reported to use INO. There is a wide variability in management practice of PPHN across Indian NICU. Then there is an urgent need of structural T and echo, and formulation of evidence-based national guideline for standard management of PPHN as per availability of the resources. So take-home message is INO is the pulmonary vasodilator of choice. Hypoxia and hyperoxia both should be avoided in PPHN, and alkalosis and hyperventilation is also avoided. Okay. Thank you.
Thank you, Dr. Shivin. I think someone from HIMS can take over for the next talk.
Good morning, all. Myself, Dr. Deepak Zaibhai. I'm presenting the topic pulmonary hypertension in bronchopulmonary dysplasia. Introduction. The pulmonary hypertension affects around 16 to 25% of the infants with BPD. It increases the risk of mortality and long-term complications. The mechanism of pulmonary hypertension in BPD are unclear and appear to differ from the key alteration of the vasoconstrictor and vasodilator imbalance seen in PPHN. In 2017, the meta-analysis for the BPD and PPHN in-hospital mortality ranged from 6% to 38%, which was 5 times greater odds of pre-discharge mortality compared to the subject with the BPD alone. And another meta-analysis, in-hospital mortality rate was 16% for patients with BPD and PPHN, and cumulative mortality rate was 40% at 2 years follow. The current concept of pathobiology of this PPD and pulmonary hypertension and BPD, in case of extreme preterm, the pre and postnatal impact of exogenous risk factor on a structural and functional immature lung, and also associated factors hyperoxia, intermittent hypoxia, barotrauma, inflammation, hemodynamic stress from the PDA, elevated pulmonary artery pressure, and lead to postnatal impairment of the angiogenesis and alveolarization that lead to postnatal hyperoxia and hypoxia triggered vascular remodeling. And this leads to abnormal vascular function, that is increased tone, altered reactivity, impaired metabolism, and also a structure, that is smooth muscle proliferation, altered extracellular matrix structure. And in case of older infants, the repeated cycles of this progressive respiratory insufficiency, hypoxia, and compromised pulmonary perfusion aggravates the pulmonary hypertension and lead to increased mortality in the BPD associated with pulmonary hypertension. Diagnosis. The echocardiography diagnosis and monitoring of PPHN. Indications are if the severe respiratory compromise is present in any preterm infant less than 28 weeks of gestation, in any infant with established BPD at the corrected age of 36 weeks gestation and before discharge, in any infant with prolonged oxygen requirement, postnatal growth, poor growth and unsatisfactory clinical improvement, and has also been suggested at 7 days of life to identify the infant at risk for pulmonary hypertension associated BPD. Then what are the determinants of risk factors in echocardiography? Low risk and high risk factors. Low risk factors were minimal right atrium to right ventricle enlargement, no right ventricular systolic dysfunction, RV by LV ratio less than 1, then tricuspid annular plane systolic exertion normal, and S by D ratio less than 1, and PAT, that is pulmonary artery acceleration time, more than 100 milliseconds. And high risk factors were severe RA by RV enlargement, RV systolic dysfunction, RV by LV ratio more than 1.5, and TAPSI decreased, and S by D ratio of more than 1.5, and PAT ratio of less than 70 milliseconds, and pericardial effusion. Then role of MRI and CT. These are the essential non-invasive imaging modalities in suspected or confirmed pulmonary hypertension. The MRI offers ability to assess the pulmonary and systemic blood flow, pulmonary regional perfusion, pulmonary artery and aortic diameters, ventricular cardiac function, and myocardial tissue characteristics. There is increase in PA by AO and MR-derived LV in systolic eccentric index associated with increased length of stay and duration of respiratory support in the BPD infants, and associated with the pulmonary hypertension therapy during hospitalization and at discharge. Then role of CT is to detect the pulmonary parenchymal disorder, thromboembolic disease, vascular abnormalities such as pulmonary vein stenosis. And the significant risk of sedation and general anesthesia in the pulmonary hypertension patient needs to be balanced against the potential gain of information of MRI or CT studies. Then diagnostic cardiac catheterization. In pediatric pulmonary hypertension, prior to the initiation of pulmonary vasodilator therapy, considered before introduction of second pulmonary hypertension triggered medications. Advised if the pulmonary hypertension worsens under dual pulmonary hypertension targeted therapy, or if an unsatisfactory response to pulmonary hypertension triggered pharmacotherapy is seen in any infant with pulmonary hypertension at corrected postnatal age of more than 3 months. Then biomarkers. In response to ventricular wall stress due to pressure overload and or volume expansion, cardiomyocytes secrete brain natriuretic peptide and N-terminal cleavage product. That is BNP is strongly dependent on the postnatal and gestational age, while anti-pro-BNP has a longer half-life, and absolute values of the anti-pro-BNP have a high inner individual variance. Both have limited value in establishing the diagnosis or severity of pulmonary hypertension, especially in young infants. Then management. TRV more than 2.5 millisecond and TAPSI of less than Z score -3 and PAT ratio, that is pulmonary artery acceleration time, of less than 70, RV by LV and systolic ratio of more than 1.5, and LV and systolic eccentric index of more than 1, and S by D ratio of more than 1.5 considered, and also a NT-proBNP. These are the screening echocardiographic findings. If pulmonary hypertension is suspected, then optimize the ventilation strategy first. And the goal of SO2 is more than 93%, and consider diuretic if required. Then pulmonary hypertension is confirmed, then optimize ventilation, and the goal of SO2 is more than 95%. Then again do a clinical evaluation, echo finding, repeat NT-proBNP, consider cardiac catheterization. If improvement is there, then re-evaluate within 1 month. And if worsening was there, then start sildenafil IV or per orally. Then again do a clinical evaluation, echo, and repeat NT-proBNP. If improvement is there, then re-evaluation within 1 week to 1 month. If no improvement, then consider cardiac catheterization and consider endothelin receptor antagonist. If improvement was there, then again do clinical evaluation, echocardio, and NT-proBNP. If again worsening happen, then do a cardiac catheterization and consider advanced therapies. Then these are the sites such as phosphodiesterase 5 phosphodiesterase 3 inhibitor and endothelin receptor antagonist that has previously covered in the session. And these are some new drugs such as Riociguat and Sinagat that act on the guanyl soluble guanyl cyclase, rho kinase inhibitor, L-citrulline, and new phosphodiesterase 5 inhibitors, and endothelin A receptor antagonist. Then we see drugs one by one. First is sildenafil, phosphodiesterase 5 inhibitor. The dose is for only 1 milligram per kg every 6 to 8 hourly. Start with the low dose of 0.3 to 0.5 milligram per kg per dose and increase gradually to 1 milligram per kg per dose as tolerated. And the IV dose is 0.25 to 0.5 milligram per kg per dose every 6 to 8 hourly, and titrate it slowly and administered slowly over 60 minutes. The side effect of sildenafil is hypotension, GERD, and irritability, bronchospasm, nasal stiffness, fever, and rarely priapism. The lower the dose or switch to alternate therapy if not tolerated. Then second is milrinone IV, phosphodiesterase 3 inhibitor. The dose is 0.15 to 0.5 microgram per kg per minute. Lower dosage range when used with the other vasodilators. Side effect was arrhythmogenic, hypotension, decreased myocardial perfusion, caution with renal dysfunction, and may need to add a pressor such as vasopressin to mitigate the effect of decrease in systemic pressures. The next one is bosentan, the endothelin receptor antagonist. Dose is 1 milligram per kg per orally 12 hourly as a starting dose, and may increase to 2 milligram per kg twice a day in 2 to 4 weeks. Intolerated and liver enzymes were stable, and side effect was liver dysfunction, VQ mismatch, hypotension, and anemia. Monitor the LFT, monitors CBC, teratogenicity, precautions for caregivers. Another is inhaled iloprost. I know dose is 2.5 to 5 microgram every 2 to 4 hourly, and can be given as a continuous inhalation during mechanical ventilation, and can titrate dose from 1 to 5 microgram, and frequency from every 4 hour to continuous. Side effect was bronchospasm, hypotension, ventilator tube crystallization and clogging, and pulmonary hemorrhage, and prostanoid side effects, GI, such as GI disturbances, and maybe it is teratogenic to caregivers. And so need to monitor for clogging of the tubing, and may need further dilution. It may need bronchodilator or inhaled steroid pre-treatment with the bronchospasm. Then next drug is IV epoprostenol. Starting dose was 1 to 2 nanogram per kg per minute, and titrate up slowly every 4 to 6 hourly to 20 nanogram per kg per minute. Need to increase the dose at regular intervals because of tachyphylaxis. The side effect is hypotension, VQ mismatch, and need a dedicated line. Every short half-life, very short half-life with high risk for rebound pulmonary hypertension with brief interruption of the therapy. And the line-related complication was there. Then next drug is treprostinil. Start at 2 nanogram per kg per minute, and titrate every 4 to 6 hours up to 20 nanogram per kg per minute. Then slowly increase the dose as tolerated. The side effect was subcutaneously local site pain, IV, similar risk as with the epoprostenol, but the treprostinil has a longer half-life, which reduces the risk of severe PPHN with interruption of the infusion. These are the other drugs for pulmonary hypertension associated with BPD, but these are having a limited data on the and also a limited experience with these drugs. First is tadalafil, which is a phosphodiesterase 5 inhibitor. You can use alternative to the sildenafil, and having less frequent dosing. Then another is Richa Joshi, that is stimulator of soluble guanylyl cyclase, has a dual mode of action. So this was the soluble guanylyl cyclase activator and stimulator. Then macitentan, that is endothelin receptor A as well as endothelin receptor B receptor antagonist. It has no liver toxicity and does not lower the sildenafil levels. Then ambrisentan, that's also endothelin receptor A1A receptor antagonist, may increase the liver transaminase and does not lower the sildenafil levels. Thank you.
The Vadia team can take over for emerging therapies in ECMO.
I am audible.
Yes.
Yeah, good morning, everyone. I am Dr. Rahul Agrawal from Vadia. Mainly, I will be talking about refractive PPHN today, focusing mainly on the management parts. So, whenever there is a persistent hypoxemia, despite the standard INO, once we optimize the ventilation and adequate inotropic support, still the not improving. So, we label as refractive PPHN. Mostly, we see in the neonates like with underlying condition like severe RDS, fulminant sepsis, CDH, or lung hypoplasia. So we have seen that the incidence of INO not response In term babies, lies between 21 to 31%, and in the preterm it lies around 18 to 44%. And whenever we have a PPHN with underlying severe meconium aspiration, severe birth asphyxia, RDS, so generally it's a predictor ki INO won't respond. So there are some other echo finders also that predicts there is a INO not response. So first is lower left ventricle global strains. It mainly tells there is a LV dysfunction, and whenever it's associated with moderate to severe RV dysfunction, means we can say there is a biventricular function. Second will be if there is a lower TAPSE, tricuspid annular plane systolic excursion, with lower LV global longitudinal plane peak strain. This all tells there is a marker of RV dysfunction. So when it's associated, mostly it's INO not response. Or third thing is whenever there is a left ventricle eccentricity index. Mainly in this we see right ventricular pressure load. Whenever there is a septal flattening, that can lead to left ventricle compression, and most likely the child will need ECMO in the future. So what are the causes of different INO not response? Mainly the first thing is left ventricle dysfunction. The most common causes are birth asphyxia, myocardial ischemia, or heart conditions like hypoplastic left heart syndrome. So in this, what happens? Because of the non-functioning of the left ventricle, there will be increase in the pressure in the left atrium. That leads to increased pulmonary congestion already. And once we start the INO, it will lead to further pulmonary congestion. So that will lead to pulmonary edema. That's why in the left ventricle dysfunction, INO is avoided. And what we see in the echo, in the PDA, we see right to left shunt. But in the PFO, there will be left to right shunt. And chest X-ray, we can see the features of pulmonary edema. So the main strategies in left ventricle dysfunction will be to improve left ventricle dysfunction. We can give PGE1, and normally we should maintain a lower sets for this. So how we manage a left ventricle? First thing, whenever there is a respiratory failure, FiO2 requirement is very high, around 70 to 80%. The first thing, we should optimize the alveolar ventilation and lung recruitment. Plus, we should rule out the pneumothorax air leaks. Once this all are sorted, first we should do the echocardio and see the dysfunction. If it's left ventricle dysfunction and we have some underlying causes like birth asphyxia, sepsis, all we should treat first. Then we see the BP, if it's normal or lower BP. If it's normal BP, we can start with milrinone. But if it's lower BP, we should start with low dose epinephrine because milrinone causes hypotension. And if it's a pulmonary edema is there, we can give a diuretics, we can optimize the MAPS. Then second comes the severe right ventricular dysfunction. For managing right ventricular dysfunction, same strategies. First, we should always rule out air leak. We should optimize the alveolar recruitment. Then always it's preferred to do a 2D co before starting INO to confirm whether, to rule out whether any CCHD is there or confirm the PPH. And once we start with INO, we see the dysfunction. Either there will be no RV dysfunction or there is a mild dysfunction. So in that, if the FI root requirement is less than 60, we manage by just optimizing the MAP. But if the FiO2 requirement is increasing, we can add milrinone because it decreases the pulmonary vascular resistance. Second thing, if it's a moderate to severe right ventricular dysfunction, we see whether BP is normal or hypotensive. If it's normal, we can give milrinone, or second option can be low dose epinephrine or dobutamine. But if there is a hypotension, so we should start with low dose epi. With that also, if the FiO2 if it's not improving and FiO2 requirement is more than 60, so generally we prefer vasopressin over norepinephrine because there are limited studies which tells how much non-epinephrine decreases the pulmonary vascular resistance. Apart from that, if there is a duct is closed restrictive in right ventricle dysfunction, we can give PGE1, and once there is a hypotension is resolved, FiO2 is still more than 60, we can consider adding milrinone in that. And the third is intrauterine duct closure. Whenever there is an intrauterine duct closure, the baby will end up in the severe PPHN with a severe right ventricular dysfunction. So in this also, mostly it's seen INO won't respond. So the main treatment will be pulmonary vasodilators, and if there is a refractive PPHN, we need ECMO for this. And the other causes can be left-sided obstructive lesion like aortic stenosis, hypoplastic left heart syndrome. If there is a CDH, renal agenesis, that will lead to pulmonary hypoplasia, or if there is severe parenchymal lung disease, severe meconium aspiration syndrome, fulminant sepsis, severe RDS, or sometimes if there is a genetic or acquired impairment, like already it's discussed, there are different pathways for vasodilators, CGMP, CAMP, oxide. So if there is impairment in that, the INO won't work. And last is insufficient dose response. So we'll discuss the different pulmonary vasodilators. There are three pathways. First pathway is nitric oxide pathway. In this, mainly L-arginine will convert into nitric oxide that will stimulate the SGC, that is soluble guanylate cyclase, that will convert the GTP into CGMP. And CGMP mainly responsible for vasodilation. So what happens? This CGMP will metabolize to GMP with the help of phosphodiesterase 5. So our target will be to inhibit this phosphodiesterase 5 so that the CGMP will be for the longer time, so that can increase the vasodilator. So for that we use sildenafil. There is one more drug available, SGC stimulator, like Riociguat. So sildenafil already has been discussed before. Sildenafil improves the oxygenation, reduce mortality, and mainly it's used where there is a non-availability of INO, or when there is a we can use as a adjuvant to INO in INO resistant, or whenever we want to wean the INO, we can use this. Or if the child requires the PPHN management for a chronic treatment, like in the case of BPD and CDH, so we can use the sildenafil. And we all know it's metabolized by liver. So before starting sildenafil, we should always rule out there is no hepatic dysfunction. And second thing, there should be normal ventricular functions. So second comes is endothelin pathway. In endothelin, what happens? There are two things, endothelin A and endothelin B. Endothelin A is mainly responsible for vasoconstriction, and endothelin B is responsible for vasodilation. So what we do is there is an endothelin receptor antagonist, bosentan, that is non-selective. So once when we give bosentan, it inhibits the ETA. So there will be vasodilation. Second is ambrisentan. This is specific antagonist, ER antagonism. So bosentan is mainly a non-specific endothelin receptor antagonist. What happens in the PPHN? There will be increase in ETA1 vasoconstriction, and there will be decrease in ETB that leads to vasorelaxation. So bosentan will uh, inhibit the ETA1, so that leads to vasodilation. And this can also be used in a chronic therapy, mainly in the pulmonary hypertension associated with BPD or CDH. Now, uh, third mechanism where we use prostacyclin agonist that will mainly increase the prostacyclin receptors, and that increases the AC, adenylate cyclase, that again changes ATP into CAMP. The CAMP is same as CGMP. They both do the vasodilation, and again the CAMP will metabolize by the phosphodiesterase 3. So if we give a phosphodiesterase 3 inhibitors like milrinone, we can improve the vasodilation. Or there are some prostacyclins analogs which are available like ilioprost, treprostinil, and there are some emerging drugs like prostacyclin agonist receptors like selexipag, which can also be used for vasodilators. So this is the same thing, other pulmonary vasodilators. Already I told PGI and PGE1. So these are the drugs which we have discussed, adenosine, alprostadil. Further, we'll discuss this. Then there are some other available like bosentan, ilioprost, milrinone, sildenafil, tadalafil. So iloprost, it's available both in intravenous and inhaled form. It can be used alone also because some of the studies have shown its efficacy is equals to INO, and sometimes it's used with combination with INO also. And the dose is 1 to 2.5 mcg per kg, uh, divided into 2 to 4 doses. Second is Beraprost. This is also a oral formulation which is still not available in India, but it has shown to improve the pulmonary hypertension in adults and children with CHDs. Still, it's under trial how much is the efficacy. Then third is prostaglandin E1. Uh, Aerosolized alprostadil can be used for treatment pulmonary hypertension in adults, and there are some of the studies which have shown it's useful in the neonates also. And the commonly used dose which we use for INO resistance is 150 to 300 nanogram per kg, which can be diluted in saline and can be given as a continuous nebulizer. Then the steroid. There are some of the recent evidence which shows that steroid is useful mainly in the neonates or preterm babies with septic shock, because the H cord increases one CGMP, which causes vasodilation. Second, it decreases the inflammation also. So IV methylprednisolone has shown to uh, decrease the duration of oxygen dependent in neonates, mainly with the meconium aspiration syndrome. And it can be used as a rescue therapy prior to starting ECMO, or if we have a time to arrange for that. So there was one journal uh, published in European Journal of Pediatrics, where they have given and where they have proposed an practically algorithm which can be used for second line, third line management in the case of INO not response. So what they did mainly, they have done synergy with various vasodilators with INO, and they whatever is mentioned in the green, that all shows they had a synergistic effect, like adenosine with INO, alprostadil with sildenafil, INO with adenosine, INO with bosentan, INO with milrinol. So after that, they proposed one algorithm. So the first line always is the basic management, that is euthermia, euglycemia, eyes and ears should be properly closed, the sound should not be there, there should be adequate ventilation, there should be adequate uh, inotropes should be used, H-cot if requiring, the child should be properly sedated. With all this, if I know, and if with all this, if there is no improvement, then we go for the second line. Second line we use is nebulized iloprost. With the iloprost also, if there is a impaired contractibility, we can add milrinone. And if there is a right ventricular failure with a duct closing or restrictive duct, we can give alprostadil. With all this also, if there is no improvement, the third line is bosentan. Although the bosentan we have only oral form, but it had shown there is a synergy with the iloprost and the INO. So third line we prefer as bosentan. And the last fourth line is adenosine. Adenosine also does vasodilation, but we have very limited evidence for this. And with all this, there is no improvement. We should always side by side prepare for the ECMO, because if the child doesn't improve with this, in the last we need ECMO for the baby. So there is again one review where new review 2020 New Review 2020, where they told whenever we use the different drugs, like INO with Milri, INO with prostacyclin, always there will be more synergistic effect of that, and it improves the PPHN better. So next comes ECMO, extracorporeal membrane oxygenation in PPHN. The indication for ECMO will be whenever there is a worsening oxygenation index requiring more than 40, or the child is deteriorating very fast with the ionized nitric oxide. So we directly go to the ECMO. We have two types of ECMO, veno arterial and veno venous. Both can be used, but if there is a normal biventricular function, we can use the veno venous ECMO. And there are many studies which showed there are around 67% survival on ECMO in the PPHN. But the mortality also rises if there is a coexistent morbidities like severe sepsis, omphalocele, and CDH. So there are some contraindications for ECMO, mainly if there is a active bleeding, grade 3, grade 4 IVH, or if there is a irreversible cardiac or lung disease. And generally, if the baby is less than 2 kg or less than 34, we avoid giving ECMOs because there are problems with the putting lines and all. So the main objective of the ECMO is we should early identify the Anu not responder, because the minute we start ECMO, the better will be neurological outcome. And that main is time matters, because as we delay the ECMO, there will be increased chance of multi-organ failures and neurodisability. And now emerging therapies, there are different therapies which are still under trial, which showed little effects on increasing the PPH, like L-citrulline, citrulline that will increase the nitric oxide, that will go and stimulate the HGC, that will stimulate the GMP, that will do the vasodilation. Then SGC stimulator, already we discussed riociguat. Then Rho kinase inhibitor that decreases the vasoconstriction. Then there are others like antioxidant. Already we discussed newer PGE5, phosphodiesterase 5 inhibitors like tadalafil. And there are some specific endothelin A antagonism like ambrisentan and citaxantan. Thank you.
Hi, can you hear me? Good morning, everyone. Am I audible?
Yes, Dr. Bhatt.
Okay, thank you. So this last session, we're just going to talk about some interesting cases of pulmonary hypertensive crisis that we've managed in our unit. So the first case, this was a term delivered by LSCS 3,600 gram child who was born of meconium stained amniotic fluid. The child did not cry after birth and had Apgars of 4 and 7. The child required intermittent positive pressure ventilation followed by CPAP in the delivery room. This child the call came from a government hospital, which was a tertiary referral hospital on day of life 3. The child was on maxed out on the conventional ventilatory settings and had an FiO2 requirement of around 100%, but was saturating only around 50 to 60% on this. He had severe metabolic acidosis on his blood gases, and the chest X-ray showed mild meconium aspiration type of a heterogeneous lung picture with query black lung PPHN was a suspicion. And they also wanted to rule out congenital cyanotic heart diseases because echo was not available in this institute. So the baby was initially empirically over there, started on injection norepi, injection adrenaline, and sildenafil infusion. Now, this was going to be a very high-risk transfer, considering if it is severe PPHN that we're dealing with, then we're worried about the pulmonary crisis worsening and with baseline saturations of only 50 to 60%. And considering no echo was done, it was very tricky to even start this child on any PGE1 for duct-dependent right ventricular diseases. So, but the high risk was explained to the relatives, and with necessary high-risk consents taken, the child was transported. Fortunately for us, the child saturated well during transport, but he required, as you can see, almost 4 to 5 infusion pumps, and he was brought on C1 Hamilton ventilator. So on admission, baby was immediately continued on the conventional ventilation with high pressures of 25/7, FiO2 requirement of 100% and rates of around 45 or 50. At On receiving on the bed, the child again had a pulmonary crisis episode where the saturations fell to around 40 to 50%. Heart rates were still holding steady at around 150 to 170 per minute. And this was the X-ray picture that we're talking about. Urgent bedside echo was done, and the findings of the echo are as follows. So as you can see in the left upper image, this baby had a, okay. So as you can see, you can make out that, so you can make out that the LV is smallish in size on eyeballing. This is just the eyeballing apical 4-chamber view using a 12S probe for a smaller child and a 6S probe for a bigger 3.5 to 4 kilo child. So you can see the RV is dilated and the LALV is slightly compressed. This is now opening up into the 5-chamber view and the LVO, and then eventually the RVO. So this was just the eyeballing which was done, okay? And then the colors were put. You can make out there's not much of TR, but there is some MR that you can note, okay? And then eventually an M mode was taken for measuring the TAPSE that we're talking about in the previous lecture, that is tricuspid annular plane systolic exertion. So this, a normal value of around 0.8 to 1.2 is taken, or you take it as a standing TAPSE. So if you have your waves which are standing, then it is a standing TAPSE, which is usually implicative of normal functions, normal right ventricular functions. But unfortunately, this baby has a sleeping TAPSE with values were around 0.6, 0.7. Now, furthermore, we looked for, since we did not have a significant TR, we did not find a TR jet, which is also expected when you have RA-RV dilatation. You will not find a significant TR, but you have an MR. So an MR was also significant of around 300 to 350 centimeters per second. The child had a smallish LV. As you can see in this plaques view, you can see the LA, LV, the aorta. And then we are going ahead to calculating the right ventricular outflow. And the child also did not have a good fractional shortening and ejection fraction. So there was some cardiac dysfunction associated with this disease. And the last few images that we will discuss are, yes. So you have interventricular septum, which is flattened. This is seen in the short axis parasternal view. And then you go ahead and look at the arch and the ductal views. The arch showed some flow acceleration. And then there was a duct which was bidirectional, predominantly right to left. So all in all, the echo findings were suggestive of severe PPHN. Sorry. All in all, the echo findings were suggestive of there was aortic insufficiency and there was an MR. There was a decreased left ventricular outflow, because of which we reduced the norepinephrine and we gave the child some afterload reducer in the form of milrinone. The LV was small and compressed. This could have been secondary to the high ventilatory pressures that were required to ventilate this lung. This could have been because of the dilated RA and the RV and because of the interventricular dependence. So HFOV was avoided in this particular case to avoid continuously high distending pressures. A fluid bolus was given cautiously in this child, and further measures to bring down the RV pressures and hence help in the LV opening were made. Epinephrine was continued in the low dose for its inotropy. The RV was dilated. The RV had dysfunction. You had a TAPSE, which was on the lower side. So Milry was continued in this scenario. And because the PDA was bidirectional and there was a D-shaped or interventricular flattening, which was seen, which was implicative of moderate to severe PPHN, the child was commenced on inhaled nitric oxide. INO was started at 20 parts per million, and it was continued for around 24 to 48 hours. The subsequent echoes could now demonstrate a TR. The LV has started to open up. The RV was starting to normalize in its size, and now we could get a TR of almost 75 to 80 plus right atrial pressures. So that was implicative of severe PAH. The saturations eventually, which were as low as 40 to 60% initially, stabilized after 6 to 8 hours of admission. The baby remained ventilated for around 6 to 8 days. INO was given for 3 days and tapered as per unit policy. The child unfortunately grew a resistant Klebsiella, for which the child needed tigecycline and colistin for at least 14 days. The baby eventually recovered and was discharged with a normal MRI brain. The second case, this was a 35-weeker born of normal Liker by LSCS. No instrumentation was required. The child cried after birth and was around 3 kilo in weight. Abgas were around 6 to 7, and the child was intubated in the delivery room itself for respiratory distress. History in the outside hospital was the baby was on conventional ventilation with maxed out settings, FiO2 requirement of 100%. PIP requirement was 25, PEEP of 5 to 6. Saturations, in spite of giving 100% FiO2, were maintained only at 50 to 60%. Chest X-ray was given an RDS grade 2, grade 3 kind of a picture outside, for which they had given a surfactant outside. They had managed to do an echo outside, which showed severe PAH with biventricular dysfunction, and the child was also in shock, for which the child was started on Dobute, Norepi, and sildenafil infusion outside. So this transport was an extremely high-risk transport. The child, again, we took a high-risk consent, transported this child on a transport ventilator with saturations of 50 to 60. Important thing here is you need to hold your nerves during the transport. There is no reason to panic because the heart rates were holding steady. The child was still run on inotropes throughout the transport, and it was a short transport of around 20 minutes. Once we received the child, considering the RDS type of a picture, considering that most likely this PPHN was secondary to a poorly recruited lung, this child was put on high frequency ventilation. Initial requirement of MAP of around 18, delta P of around 28, FiO2 of 100%, and a frequency of 9 to 10. Once HFOV was started, in the next half an hour to 1 hour, inhaled nitric oxide was also started at 20 parts per million. Initially, we did not give any inotrope. Just by recruiting the lung and starting inhaled nitric oxide, we achieved saturations of around 94% within half an hour. So the key here was we had an RDS, which initially the referring hospital tried to recruit using surfactant and continuing invasive ventilation. He just needed high frequency ventilation to recruit all the alveoli before we went ahead and started inhaled nitric oxide. So this child had a severe TR, which you can make out with this blue jet over here at the level of the tricuspid valve. So this is the 4-chamber apical view on which we have applied color and then a continuous wave Doppler. You can make out that the TR max here is almost 3 meters per second or 300 centimeters per second. So using the Bernoulli's equation, the RVSP is calculated as 4 into the TR max, which is 3 multiplied by 3 multiplied by 3 multiplied by 4 plus right atrial pressures. So the RVSP is around 40 to 45 in a 35-weeker child, which is at least moderate PPHN. Another view where you can sometimes observe your tricuspid jets are Plaque's views, which when you tilt towards the liver or anteriorly, you will kind of get your RA and the RV to open up. And this is the TR that I'm talking about. So sometimes if you don't get a TR in the 4-chamber apical view, you might use the Plaque's view. Once you get your LA, LV and the aorta, you can tilt your probe a little anteriorly and you can probably get this view, which gives you your RA, RV and the tricuspid valves, which give you a tricuspid regurgitation. Moving on, you can then tilt your probe such that your pointer points towards the left shoulder and you can get your ventricular views, which will tell you your interventricular septal positions. Okay, so sometimes if you don't get a TR, but you still think this child strongly has a PH, you won't get a TR if there is an RV dysfunction or the RA-RV is dilated. In this case, you might have to look at you will still have to look at your interventricular septum. So usually you have your LV, which is circular, and the RV, which is sitting over it in a crescent shape, which is the O-shaped LV, where your right ventricular pressures are less than 50% of the left ventricular pressures. Eventually, if your right ventricular pressures start becoming around 50 to 75% of the left ventricular pressures, you will have flattening of the left interventricular septum, or the D-shaped ventricle that they're talking about. And if your right ventricular pressures are suprasystemic, that is more than 100%, in that case, you will get your crescent-shaped LV. In this case, yes, you have bowing of the interventricular septum into the LV, which is implicative of severe PAH. Another way to also classify PPHN is your extra pulmonary shunts, extra alveolar shunts, which are at the level of the PFO and at the level of the PDA. So if your PFO is shunting bidirectionally, so also the PDA is shunting bidirectionally. You can look at what percent of the cycle has a right to left shunt. So here you have a duct. This is the ductal view. Here you have a duct, which is then, when you put Dopplers on this, you can see that almost 60% of the cycle has left to right flows, but there is a right to left flow in 30% of the cycle. So this is a bidirectional duct. And this view, which is a subcostal two-chamber view, you can make out that there is a bidirectional shunt at the PFO level also. So these are some of the images which will tell you that this child has PAH. There is significant PR. There is interventricular flattening, and then you go ahead and treat. So prime importance, first, recruit your lungs well. So adequate lung recruitment is of paramount importance. Avoid over-distension. Then you start pulmonary vasodilation. So starting a pulmonary vasodilator is not going to work in this condition where you have a lung which is under-recruited. So your ventilation principles, lung volume, PVR. So you need to optimize your lung volume. You might use volume guarantee mode of ventilation. The target is that your pulmonary vascular resistance is the lowest when you maintain your lungs at its functional residual capacity, or FRC. If you over-distend your lung, you will have elevated alveolar resistance. And if you under-ventilate your child, or if your lung is under-recruited, you will have elevated extra-alveolar resistance. So you want to find the sweet spot of the FRC, which is only going to happen once you slowly and steadily start increasing the pressure to a point where your saturation starts worsening, and then you come back to the original pressure where you have optimal saturations. So try using open lung strategies, try using volume guarantee ventilations. Then you support this pulmonary pressure by using pulmonary vasodilators while you avoid your over-distension or air leaks. Minimize barotrauma, volutrauma, and if you require PIPs of more than 25 to 28, you might consider high-frequency ventilation. Depending on your heterogeneous lung disease, you might give 2 to 3 centimeters higher than the MAP you were giving on conventional ventilator. And if you have a homogeneous lung disease, then you might give pressures, MAPs, similar to that you were giving on conventional ventilation. So if you consider this the loop of inflation, you ideally want to ventilate on the loop of expiration. That is the ideal position where you want to obtain, and you want to use lung recruitment strategies. A lot of times, most of the times, all the babies that we receive in the unit, we do perform lung ultrasounds just to confirm that lung sliding is present. We do not have any pneumothorax associated with transport and handling. So initially, if this lung was having confluent B lines or compact B lines or an alveolar interstitial kind of a picture, which is of the atelectatic or the collapsed lung, we want to move into this zone, which is lots of A lines, minimal to no B lines, and an open lung picture. So the course bedside echo was performed, suggestive of grossly dilated RV, as we've discussed. Injection Dobute was switched to injection Adri for the ionotropy. Injection Nor-Epi was tapered and stopped, and Milri was added for lucitropy and afterload reduction. As the saturation reached acceptable targets, eventually within 24 to 48 hours, INO was stopped as per unit protocol. Ventilation settings were tapered gradually, and the child was extubated by day of life 6. The last case, which we'll just quickly go through, this was a preterm delivered at 31 weeks of gestation, had oligohydramnios right from 20 weeks of gestation with AFIs of around 2 to 5 in different scans. The mother had received a complete course of antenatal steroids and a rescue after 7 days of the initial course. Baby was delivered by an elective LSCS, cried after birth, but developed distress soon after. It was a 1540 gram baby. Sorry, apologies for this. 1.5 kg baby. And Apgars were good. This child was delivered, we were called for the delivery and the child was transported to us, had a high SAS score. The reason for the oligohydramnios was not known in any of the antenatal scans, but there was oligohydramnios for almost 11 weeks prior to the delivery. We were suspecting probably some kidney issues, which was resulting in the oligohydramnios, which was resulting in lungs to be hypoplastic. The child was tachycardic during transport and had RDS grade 3, grade 4, ground glass kind of a picture with probably some pneumomediastinum. Lung ultrasounds were done. Lung ultrasounds more or less in all the zones showed an grade 2, grade 3 kind of a picture. There was confluent B lines in all, but lung sliding was present. There was no pneumothorax. So this child was intubated and given a surfactant at around 2 to 3 hours of life, but the FI2 requirement progressively worsened and the child eventually needed high frequency ventilation with pressures as high as 20 to 22. Child developed hypotension, was given an NS bolus and started on epinephrine and central lines were inserted. Repeat focus still showed the lung sliding. Considering this was a crashing neonate, all the scans were repeated. Lung showed sliding present, no pneumothorax post surfactant. Targeted echo showed severe biventricular dysfunction with severe PAH, probably secondary to the bad RDS and probably secondary to the pulmonary hyperplasia that we were suspecting. Ejection fractions were poor. Initially, INO was not started, but once the child was recruited after starting the HFOV at around 6 to 8 hours of life, the child's functions improved. As you can make out now, the functions seem fairly better. You can make out there's a TR which is starting to appear, which for this preterm was around 36 plus right atrial pressures. TAPSEs were around 0.8. This is my left ventricular ejection, DTI. This is my Plaques view, which is now showing that the LV is also opened up. I'm measuring the TR again in this view, which has a TR and almost 3 meters per second or 350 centimeters per second. Right ventricular outflow is being measured over here. As you can make out, this is an LV, which has a flat interventricular septum. And now you can make out that there is a duct which is coming up, which is 50-50 predominantly. This is my duct, where we apply color. It is having bidirectional flows, with 50% of the cycle having right to left flows. Unfortunately, so this child was started on inhaled nitric oxide at around 10 to 12 hours of life at 20 parts per million. Once the functions improved, like the echo which we saw previously, the lungs did open up at the end of 24 hours, but the ventilatory requirements were still quite high. The MAP requirements were still 18 and 19 for this 31-weeker preterm. The X-ray done on day 2 of life showed a pneumopericardium kind of a picture, because of which the echo windows were not good. And this showed a spontaneous resolution at the end of 72 hours of life. The child continued to require pressures of around 16 to 18, which by day 5 of life, the lungs started again appearing hazy. There was an ET bleed, which was significant. The child had pulmonary hypertension. And this was what the echo looked like. TR continues at around 3 meters per second. TAPSE is now relatively standing at around 9 to 1, 0.9 to 1. Have good left ventricular outflows. Have fairly okay right ventricular outflows, but there is some turbulence that you can start making out now. Ejection fractions are fairly okay. Interventricular septum is still flat. And finally, the watch for the duct, which was still moderate to large, shows a predominantly now left to right duct. So we weren't sure if the duct is now starting to become a trouble, which is the reason why we started having discussions within the unit about whether this duct, which is now predominantly left to right, needs to start getting closed, or we might have to start closing it medically. So take-home messages, this slide is similar to the slides that have been discussed previously. So it is not just of paramount importance to start pulmonary vasodilators. All the supportive measures are equally important and in fact, more important. So sedating the child, having a calm environment, having less light, less sound. If it is a PPHN secondary to the lung disease, then treating the lung disease by adequate lung recruitment maneuvers, by giving surfactant, giving adequate lung pressures is of primary importance. These are just the last two slides that I would like to take on briefly discussing what the previous team discussed. So if you have a lung where you have normal cardiac functions and normal BP, then you can have your standard management supportive measures. And if INO is available, then INO. If INO is not available, but your BP is normal, you can start sildenafil. As a unit, we do not usually give a loading dose of sildenafil. We just give a maintenance dose of around 1.6 mg per kg per day or 0.07 mg per kg per hour. If you have normal BP with some cardiac dysfunction, you would start standard management, plus you would start INO with caution once the functions improve after the standard management, because starting INO in a heart which has LV dysfunction can worsen the pulmonary venous hypertension. And if INO is not available, then you might start Milri at around 0.33 to 0.5 mics per kg per minute. In a heart which has normal cardiac function but low BPs, you might consider giving a fluid bolus. You might, if you have DOPA starting, you might increase the dose. Otherwise, as a unit protocol, we usually start epi at around 0.1 to 0.2 mics per kg per minute. We might consider norepi and hydrocort to bring up the BP. Sometimes we've tried vasopressin at a low dose just to bring up the BP if our kidney functions are okay. But if this heart was already dysfunctional, then I would reduce the afterload. I would not want to worsen the upload because the heart will have to pump against a higher ICR. So I might use a combination of Adri plus Milri for inotropy and then lucitropy for an upload reduction, or a Milri plus vaso, and simultaneously explore the options for VA ECMO. This is also something which we can share as a slide. So if you have a left to right shunt, this is most likely if you're at the atrial level, you have a left to right shunt. This is usually because of a primary parenchymal lung disease, might not have PPHN. So the treatment is ventilation and lung recruitment using probably surfactant if required. If you have LV dysfunction causing pulmonary venous hypertension and an atrial level shunt, then this is usually an RV dependent systemic circulation. So you would want to avoid nitric oxide in this condition because it will worsen the pulmonary venous hypertension. You might consider your PGE1 infusion to open up the duct, which works as a pop-off valve and relieve some of the pressure of your RV. And you might give milrinone plus or minus Adri for inotropy just to have some lucitropic effect. If you have a duct-dependent pulmonary circulation like a TAPVC, in this condition, your atrial level shunt will be purely right to left shunt. And in this case, your PGE1 will work. You might start PGE1 and you get a cardiac opinion. And the condition where you have a right to left or predominantly bidirectional shunt, that is it is mostly implicative of PPHN. So the treatment will be your supportive measures, less light, less sound, sedation. You might optimize your ventilation. You give oxygen to this child to maintain target saturations of around 93 to 97%. Once you have recruited your lung, you might start inhale nitric oxide if the unit has it. And as a unit protocol, usually when we're tapering nitric oxide, we overlap it with IV or oral sildenafil. Thank you. Apologies for overshooting, but I just thought we'll summarize this talk. Any queries?
Thank you, Dr. Bhavya, very much. I think there were very comprehensive case summaries on PPHN. Just quickly, I would be keen to know, like, how is your experience with the use of INO in preterm neonates? Like you showed using it for a 31-weeker.
Yeah, so unfortunately, we didn't see much. The child was a partial responder to INO. We didn't have a good response to INO, which is why we came off the INO. But even for coming off, we were still around 24, 48 hours old when we came off. And the child did develop a pulmonary bleed eventually at day 4, day 7, but our platelets were holding steady at 1.7. And this child had an unfortunately stormy course eventually. So no, I don't think we had a significant response to INO in this child. And as also in CDH, we've not seen a good response to INO in babies who have CDH, but sometimes when we're pushed against the wall, we have given INO trials even in CDH.
Yeah, just to add on, I mean,
Yes.
PPHN, I know it's not like completely no in extreme preterm, because the concern is whether they have the vasculature which will respond. So in many cases, the non-responder rate in preterm is high. But as Bhavya was saying, when you're pushed against the wall, you are in 100% oxygen, you're not able to recruit the lung. There's a RDS component, and the lungs also have a high PVR. You can start nitric maybe at 10 ppm and get an acute response. And at least you will tide over the crisis. You will get some stability, even though it is a partial response. So I think when you reach about 80 to 100% and nowhere to go, because you cannot go beyond pressures beyond certain points. Like in this particular case, whenever there is hypoplasia, if you use higher pressures, the risk of air leaks is
Air
higher.
leaks are high. Yes.
Correct. So that's why that fine balance is there. So it's not completely contraindicated. You can
Okay.
try. If baby responds, well and good.
Okay, so maybe giving a trial at a lower dose.
Yeah, 10 ppm is okay.
Usually, matlab, I don't know, especially considering like some controversies like efficacy and safety. So sometimes it does put it in a dilemma that whether to use it or not.
Correct.
But then,
So most important is life. If you are losing the life, then you need to try. Then you can deal with the side effect, and that's what most of the studies. So all the studies for nitric for prevention of BPD and all those neuroprotective, those are useless. So you don't use prophylactic in these cases in preterm, which was all old. There are 10, 12 studies are there. That's useless. There's no role in that. But in acute pulmonary hypertensive crisis in a preterm RDS lung, you can try. And it is known to prevent, it is known to improve the acute hypoxemia. And also preterm with pulmonary hypoplasia also, it is known to prevent, stabilize these babies. And even term pulmonary hypoplasia, it's known to prevent ECMOs. So hypoplastic lungs and CDH also, as Bhavya was saying, almost 40-50% are non-responders, but we have used the babies where, they are difficult to stabilize, especially pre-op.
okay.
I would just like to add, I think one other key factor is like stopping INO if you see there's no response, especially preterm. So that we don't tend to do. Many a times we just continue INO just for the sake of
Correct.
Yeah.
Very valid point. You need to dare to wean it off. If
Yes.
you clear cut, if there is no response at all, you should wean it off completely. That is where I think where people don't do that. Correct. Very valid point.
Yes.
Thank you.
Any other queries?
I'll share one article in the group if you can. I mean, that covers most of the practical and echo aspects. Just something we wrote. That will be a good reference.
Sure, sir. That would be very useful.
Okay. Thank you, Dr. Akanksha. I think there are no questions in the chat box also. If we don't have any more, then we can end the session, right?
Yeah.
Yeah.
Okay. Thank you. Thank you, Dr. Bhavya. Thank you.
Yeah, good.
Thank you, sir.
Topic coverage by every speaker. Well done, everyone. Well done, Bhavya. Thank you.
Thank you. Thank you.